Good evening, everyone. This is
Oh, there's a gentleman standing outside. I think he was looking to continue.
Oh, yeah.
you'll be
Oh, okay.
you can buzz them in. All right. So good evening, everyone. This is the um, Health and Hospitals and Social Services Committee for Community Board 8. It is 7:04 p.m. and I would like to call the meeting to order. I'd like to start with just introduction of the committee members and any guests. So I'm Wayne DeBeetham, I'm the chair. We have
Steve Matthews, Vice Chair.
Here, and I believe another member is on her way. We also have some esteemed board members of the community board.
Hi, Laura Spalter, board member.
And we'd just like to go around and have everyone else introduce themselves who's here.
So, I'm Helen Quinn, longtime resident of Riverdale. I am an activist with Northwest Bronx Indivisible, with Hourglass, formerly the Northwest Bronx Community Coalition, NIPAN, and NYC 16 Indivisible. On the health committees of all of those.
Thank you for coming. Good.
François, a resident across the street. The first time, the second time that I'm attending a community board, the first time it was remote on Zoom.
Okay. Well, thank you for coming in person. Oh, wonderful.
Hi, I'm Deirdre Burke, no affiliations, community member, retired enemy, school principal.
Well, I'm a fan of educators, so you're not an enemy here.
My name is Michelle Mullen. I'm a reporter with the Riverdale Press, writing about both the bill we're going to be talking about and a few other health-related things.
Thank you so much.
I said that because everybody has bad memories of the principal.
And we also have some individuals from the community who are present with us via Zoom, including, I believe, Miss Angelina Turan, who's a member of the community advisory. She's the community advisory board liaison, and we also have Taylor John. They're both in the assistant director of community affairs, so they're representing one of our HHC institutions, North Central Bronx, Jacoby, and they will be speaking a little bit later. But thank you for attending today. So that being said, we do not currently have quorum, and so we are going to presently skip the approval of meeting minutes. Chair's report, not a whole lot to report. We met last month. We did not have quorum at that time, but we did discuss in large extent what some of our priorities were, as well as brainstorming and talking a little bit about some of the things that are coming up in terms of possibly doing resolutions and resolutions regarding both either some variant of the New York Health Act or in terms of general support for some variant of general health, and also the harm reduction. And that's kind of where things stand. But moving on, I believe we have a guest speaker from the aforementioned guest speakers from HHC, and I believe you have a presentation that you would like to give. And I can bring that up, and if you like, I can give you the ability to control the screen, if that's okay.
We can, sorry for the delay. There's a little glitch that I have. Good evening, everybody. I'm happy to just chat with you all since it's a smaller group. And then you can, disperse the presentation if you'd like. Either way, just let me know.
We have availability, so the choice is yours.
Okay, we can just chat. I think that's a little more intimate than seeing the screen. Perfect. All right. Thank you all so much for having us, Community Board 8 and this health committee. We really, really appreciate it. Again, my name is Taylor John. I am the Assistant Director of Community Affairs for New York City Health and Hospitals, Jacoby North Central Bronx. I have with me my colleague and my team member, Angie Turan, who she's going to introduce herself, but she's our Community Advisory Board liaison. And we are representing Jacoby North Central. And just to give a little background for those that are unfamiliar with New York City Health and Hospitals, we are a public health system, the largest in the country, that provides personalized care, comprehensive care. We offer services for all, regardless of their ability to pay. Those services, include being cared for with dignity, respect, and with safety in mind. We are the advocates and the health champions for our community and our patients, and encompassing our work, our vision is care for New York City, no exceptions, right? So regardless of your ability to pay, your demographics, whether you have immigration status or not, we accept you all, and it is a safe haven. And I just want to re-emphasize that, especially in the time that we are in right now, that folks know that our doors are open, regardless if they have insurance or not. And a little bit about the work that we do. So our work falls within ambulatory care. So that is the division that supports outpatient services, right? So think of your primary care physicians, your OBGYN, gynecology, right? Pediatrics, virology, anything that doesn't require dental, an overnight stay is what is housed within ambulatory care. And my direct boss is the Associate Executive Director of Ambulatory Care Services. And we are responsible for health initiatives at Jacoby NCB. This has been rebranded. It used to be Community Affairs. It's been called Health Initiatives. And that is essentially our way of connecting with the community in the Bronx, all over the Bronx, as well as parts of Upper Manhattan and Lower Westchester, because we do get patients from there, those areas, because we are a level 1 trauma center. So we're the closest hospital for many of those areas. And we go out into the community. We bring the community to us. We host health fairs, programming, workshops. If you wanted us to come into your meeting or to an event that you had and you wanted us to present or to table, we are happy to bring our clinical team and providers. So that's a little bit of a gist of the work flow that we do. Also within my report is the community advisory boards. They are both at Jacoby and North Central Bronx. I'm not going to talk too much because I want to give Angie that platform and space so that she can share a little bit more about it. But our community advisory boards work in tandem with you all, similar to the work that you're doing, where they are our champions and advocates within the hospital. Some other things that we do in our space. So I am a public health researcher by training, and I'm a doula, and I have clinical background in gynecology. And the work that we're doing now within our team is actually talking about trauma-informed care within our ambulatory care spaces. So that is also something that you are interested in regards to mental health and gender-based violence. That's something that we can certainly partner on. We have an amazing domestic violence team, emergency medicine and trauma team, as well as our social workers who I collaborate on with those presentations. So actually tomorrow I'll be presenting to our nurses around trauma-informed care and how to show up for a patient as it relates to trauma and the complex traumas that we may see. That includes gang violence, it includes early pregnancy, it can include surgeries that are performed overseas if a patient comes from another country and we may not practice that service and that aspect of care here. And so we're talking a lot about how to not only help our patients, right, but also how to help ourselves. So those are some ideas, and we've gone on a system level. So I presented last week to our providers. Tomorrow I present to our nursing team. Next week I'm working with our clerical team, so that's administrative. So we go through different levels. So just want to give you all, a scope of what a partnership could look like. And that's why we're here today. We are here because this team is new. This is recently has been put under my purview about 6 months ago. Angie is new to our team. She just started. So we're really just trying to make connections in the community, get to know our faces. You may have seen other people from Jacoby NCB who have shared this similar work. That work has now been given to my team, so it's a little bit different. That team is public affairs, and they're going to be working on like the marketing and the communications. But if there's anything that we can do to support you all in connecting yourselves with Jacoby NCB, we'd be happy to do that and connect with you all. So again, just want to thank you for your time. I'll leave some space if there are any questions. All right. Here, oh, I see a hand in the back.
We had a speaker come, actually, the chief financial officer of Jacoby North Central Bronx came to my temple.
Very nice. Ellen.
Yes. And she said that the impact of the cuts coming from the federal government was already, this was September, last September 25. It was already causing reductions in the nursing staff because of the seriousness of the cuts. And they're attempting to anticipate what the impact was going to be. Have you been aware, and has that impacted your relationship with the reach out to the community and also your interaction with the patients?
Thank you so much for the question. Just want to repeat to make sure I heard correctly. So you're asking, has the impact of the nursing and the strike and any federal cuts have impacted our workflow within the community?
Yes.
Yeah, that's a great question. Thank you so much. So I will say that as our last report in our community advisory board meeting, they shared that our nurses have not been impacted. Our nurses are growing. We've had new nurses recently on the NCB side that are doing their onboarding and orientation and rotation. I don't have that exact number, but we can certainly ask our chief human resources officer and get back to the group with that. But in terms of in the community, actually, no. So what's really unique about our work here is that majority of our nursing team is within the ambulatory care space, and that is our department. That's our division. That's our direct colleagues. So we actually get to assign our nurses to go out into the community to do the outreach, to table, to give health screenings, and vice versa. A lot of times, if you don't see our nurses, you'll see one of us. And still being able to give the same kind of care. So it hasn't impacted our work. I would actually say within the last month, our increase of engagement by visiting different community boards and by going into schools, the Bronx community, the people are now aware that we exist and that this is a service that we can provide to all of you and vice versa. So our doors, our phones have been ringing. We are a very small and mighty team. So it's actually just me as the lead for health initiatives, and then Angie is supporting me with our outreach initiatives, but her primarily responsible for the community advisory board. So we're looking to build and grow our team, but we are definitely getting out there now. Within the last 30 days, our phones have been ringing for us to support fairs, which is great. So please keep that coming. I hope that answered your question.
Could you please share your contact information?
Oh, yes, absolutely. So my email address, or I'll start with my name. So Taylor John, Taylor John. Our email address, which is the best place to connect with us, is Jacoby, JACOBI, NCB, North Central Bronx, NCB, Health Initiatives at N as in Nancy, Y, C, New York City, HHC.org.
Thank you.
No problem. And we can certainly share it with our point of contact. Angie can give all that information so that it can be dispersed to you all. And then our website, just so you have a good point of reference, you can also contact us there, is New York City, NYC, excuse me, healthandhospitals.org.
Yep.
And that will show you all of our events and our programming. We do have an event calendar with all of our health fairs that we can share with you all too. And something to keep in mind is our back to school fair, which will be August 7th at North Central Bronx Hospital and August 14th at Jacobi. Last year, we did have a few community boards participate, so would love to have you all there to table or just come and say hello and enjoy the resources.
So, Ms. John, hi, Dr. DeBeetham, Lincoln alum, but I won't hold it against y'all. But I think one of the things that is clear and evident is that poverty and lack of access to care does not just cost you; it charges interest, right? So the individual who does not get their adequate primary care for their diabetes winds up with an amputation and extended hospital stay. The individual who does not have dental care and address that cavity winds up with an abscess. So what sort of things in terms of ambulatory care and outpatient care and resources in terms of outreach is HHC providing, and what sort of things can we in this jurisdiction let people know about so that they know that there are opportunities in access to care?
Absolutely. Great question. Thank you so much for sharing that. I'd like to provide an example. So recently in February, it was Heart Health Awareness Month, and we hosted a heart health event at NCB. And what we did was an all-day kind of like a conference, and we had a presentation by our cardiology team. We had our social workers present on self-care when managing complex diseases and health, issues. We had our nutrition and dietitian do a panel discussion. So they sat on a panel and we interviewed them and asked them questions around wellness, what your plate should look like, healthy habits. They did something called snack bites, where every time you have a meal, if you can get up for 5 minutes and do some walking around, and they catered it towards like our patients within our hospital, right? Walking on the hallway back and forth. What does that look like for you? We also did a Q&A session with the general community, and then we had a patient testimony. So I would say there are a lot of programs that we're building like that, where you're getting a full, robust picture, right, on the services that we offer, but also how they all work together, right, and how they work together to create something that we call whole person centered care, right, looking at the whole body from top all the way down to your toes. And what does that include? That includes social workers, that includes your primary physician, like you said, that also may include cardiology, that may include having your orthopedist there, right? Having podiatry there. So we try to paint that full picture. So I would say we've been doing that about once a month. And so certainly when I send you the schedule, I can let you know what the theme will be. The next theme that we're planning right now is around foot health and actually what you're talking about, diabetic care, hypertension, but high blood pressure. So we're planning to bring all three of those teams together and those disciplines to have this open conversation with folks. So that's one example. Directly bringing the care to the community. So one of the things that we're also supporting is with our youth. So our youth are entering into the summertime with summer jobs. Some are going to college, right? So if you have any youth in your area, which I'm sure you do, probably have neighbors. We've been working with local programs such as like YMCAs or New York City agency programs to offer TB shots and physical exams. So what we're doing is working with those organizations to carve out a chunk of time to be able to support those kids to get the vaccines and resources that they need in order to have a summer job or to go to school. We also do within a certain radius, so it has to be about 5 to 8 miles radius, we will offer blood pressure screenings. We do just ask that it's within a radius of a nearby hospital. In the event that someone does have high blood pressure, we want to be, reactive and proactive, right? We don't want to delay their care. So we work with the person who's interested. Like, for example, let's say your church, I think someone mentioned a temple, right? If your temple wanted us to come in and give blood pressure screenings, we just kind of make sure that we're within that radius. What we won't do, that this has come up, is glucose testing. So that's something that hasn't been approved yet by our nursing team. We'll do it on site, but again, if someone ends up having, high testing, very high, and we're not near a hospital or an ambulance or anything of that nature, it can pose a great risk to the patient. So those are some of our, modalities there. We're also always welcome to more ideas. I know when I visited another community board last year, I think it was Community Board 11, they talked about a mobile truck and a mobile clinic truck. And this was something that existed during the pandemic. It has not been brought back up yet, but it is something that has been a conversation amongst my team in trying to figure out how we can bring supplies and resources to folks. But we do have our harm reduction team. Those are the folks that cater towards substance use patients, and they go out into the community and offer resources there.
I would like to segue on that because I think one of the topics that has come up, and we actually had several months back, there was a group of individuals who were studying their a master's program, and there was a legislation that was in support of fentanyl test strips. And they spoke on that and kind of gave some of the details of some of the issues regarding substance abuse and some of the challenges that can happen with individuals. And I think one of the things that many of us on the board, on this committee, and the community as a whole certainly want to address is the concept of harm reduction. Mm-hmm. Right? Whether, irrespective of whether you support one thing or another, the idea of making sure that somebody's alive to see another day is something that is laudable. So what sort of harm reduction steps are you currently undertaking at North Central Bronx, Jacoby, and what outreach do you have on that regard?
Sure, that's a great question. And it's very fitting because we actually had our harm reduction team present today to our Jacoby Community Advisory Board. So I would welcome that team. I would love to put you in touch with them to have them present to you all. They would be able to best attest to that. But I will say what we've done, they work in tandem with me. So everywhere in the last year that I've gone, our harm reduction team has gone to. So they do a lot of great work in the clinic and outside the clinic. Actually, their services have now expanded. So they do have a social worker on their team as well, who is, they have a few social workers who work with our patients. But again, they're also actively looking for new patients, and they're looking to connect with folks that they may not be servicing. So one of the big areas right now is the Fordham Road in the park area, right? Down the street from Lincoln Hospital. So we're working also with other teams to be able to figure out what is the need and where are the gaps, right? I will throw this out here. Is anyone trained in using Narcan? Does anyone have naloxone training? Oh, I love seeing those hands. That's amazing. Thank you so much. So usually that is like one person that raises their hand when they're asking I'm going to ask that question. So that's something that we're offering soon. Hopefully we're going to have a session starting in July. I can certainly share that with you. It's really great. We're partnering with New York City Health to give that training, and our harm reduction team is going to co-lead it. And anyone could come to the hospital and they can get the training. They'll get a little go bag to carry with you. I don't have my purse with me right now, but it's like a pouch about this size. It has all the supplies that you need. So that's definitely one thing that we're doing. I would say also our harm reduction team is working with our primary care physicians as well. So that's really nice that they get to work in tandem. So there's a nice, smooth handoff and referral process. They're also doing different, aspects of improving their social and psychological function. So they work with different disciplines in that area as well. And they service our harm reduction team at Jacobi Institute services New York City patients, Westchester, Rockland, and Putnam County. So they actually have a really lovely reach. But again, I think it would be lovely to have the team come and share a little bit more about their work.
Let's pencil that in. I think that would be something that the community would appreciate.
Perfect.
Anyone else have any other questions?
In the context of the harm reduction, is there anything they've done to educate the community about the new virus that is out there?
I'm sorry, could you just repeat one more time? You said in the context of harm reduction and then I heard.
Any action being undertaken to educate the community about that new virus that is out there?
Antivirus, is that what you're referring to?
The
antivirus?
Yeah,
The Department of Health issued a bulletin to clinicians and public health professionals today about it, actually.
So you're asking if the hantavirus relates to harm reduction? Is that
in the context of the harm reduction activities, is there any plan to educate the community about that?
well, so I think this would be best suited for our team. I'm happy to ask the question and get back to you. I don't want to give you the wrong information, but the two issues are completely separate. One has to do with rodents, and another one has to do with substance use. And currently in this space, our CMO just shared that today. It's not of concern for our area in the Bronx right now.
That those pertaining to viruses at this point, that is more of a public, that's more of a infectious disease public health matter. Harm reduction specifically speaks to things that largely in the context of substance abuse, but in general, things that basically allow tools that allow one to mitigate their risk or their harm. Right. So the classic example from the 80s and 90s would be needle exchange for people who were injecting drugs, right, to reduce the likelihood of them contracting a disease. So it's recognizing that there will be harmful behaviors that have negative consequences, and it's really doing things in the context of saying, how can we do things a little bit better to keep you safe in that context? But you're right. I mean, that being said, it's in the news, right? So it is a concern.
If it makes you feel any better, I don't think there's been a case of antivirus in the city in decades. I can recall one when I was working at the health department, but the individual who contracted it and died did not contract it in New York City.
I was listening to the news, and there is one case in France right now. The person has been put in isolation, the person contacted in both.
Well, this all underscores the importance of having health tracing and having centers of disease control that actually do their job, but that's a topic for another day. That being said, any other issues or concerns with this particular topic? So thank you so much. We really appreciate you taking your time to speak with us. And I think we're looking forward to having more opportunities to interact. I think this region would certainly benefit greatly from a lot of the resources and things that you could provide. And obviously knowledge is power. And so the more that people know what's literally on their doorstep, I think the more we can take advantage of that. So thank you so much for being here.
No, thank you also.
We'll definitely be in touch regarding your harm reduction group.
Perfect. Thank you so much. And I'll just pass it off to Angie. I know she just had a quick announcement to share with you all. But I did just want to say, folks, if you have the ability to give and donate blood, please do. We have an extreme, blood donation decrease that's happening across the boroughs. So I strongly encourage you, if you have the ability to donate, and it's safe for you to donate, please, consult with your primary care physician. Please do. We will be having a blood bank drive soon at Jacoby, so we'll share that information with you all. And then if anyone is interested in HIV testing, we do give free HIV testing out to the community about twice a month with our HIV testing team. So we can send that schedule as well to you all so that you can share it. Again, thank you so much. I'm just going to quickly pass it to Angie.
Hi, thank you. I'll be very brief in absence of time this evening. And I could say I could come back next month and present more if you have questions. But I just wanted to talk to you about our community advisory boards. They were established in 1970 as part of the founding legislation of New York City Health and Hospitals, ensuring that community voice was heard throughout the public hospital and their operation. CAB members are volunteer residents, patients, and community stakeholders who dedicate their time and expertise to help ensure access to high-quality healthcare service in their communities. The work of the CAB is centered around three pillars: advisory, advocacy, and awareness. Advisory CAB members meet regularly at the hospital once a month. We have both the Jacoby and North Central, each the first week and the second week of the month. We met today at Jacoby, and they review programs, identify gaps, and help guide improvements in the care that is delivered here in the Bronx. I also would like to say I passed out a presentation that I could come back and review it more at depth at another time. Applications for membership for the CAB, and a flyer that gives a description of the CABs throughout the city. And with that, I want to say thank you for the opportunity to present this evening. Do you have any questions?
We have the presentation here. Do you think you'd be able to do a truncated version of it, or?
Let's see. I don't know if they're going to close I decided to stay here at the hospital.
I can do it if anything, Angie, if you have to
do it. Yeah, because it's, I should have gone first. I didn't know that. This is delightful that this group has so many questions. I love it.
Wayne, do you have the ability to share your screen by any chance? If not, I just need a few minutes to pull up the presentation.
Jaylene said that she would. Is Jaylene around?
No, we have it. We can.
You do?
Temporarily make you co-host. All right, I've made you a co-host.
Okay, I'm not seeing it on my end. Let me just email it quickly to myself. I'm working from a different computer.
All right.
It says,
can you see that?
Yep, perfect.
All right, so I can launch that, and then I can, if you need, we can just tell me next slide and we can advance it.
Perfect. This is great. All right, thank you so much. Okay, so again, our community advisory board, next slide, please. Okay, next slide. We talked a little bit about health and hospitals and our vision. So again, we are run and organized by our president and CEO, Dr. Mitchell Katz, who is a primary care physician. Again, we are a network of hospitals and community-based health centers that include long-term care and rehabilitation facilities, home care services, correctional health is also under our purview, and our health plan, Metro Plus. In the Bronx, we have Lincoln Hospital, Jacoby, and North Central. Next slide. Next slide. We talked a little bit about this, so just in the interest of time, we can skip the next two. Next slide. We talked a little bit about my role. Happy to send a link to our back to school fair so that you all can see what that looks like. So what are our community advisory boards? Angie talked a little bit about this. Next slide. Thank you so much. So again, our community advisory boards were created to operate the city's hospitals, right? Establishing and enabling a legislation that was mandated to become a part of the system, to become part of our framework, right? Our CAB members are engaged. They're interested in healthcare issues. They're carrying out our mission and our values, but they're also leaders like you all, right? I apologize for the noise in the background, perks of working at home, but there are community leaders, right? There are residents, there are patients, they are educators, they are physicians, they are just folks that are interested in volunteering, right? And overall, they encompass this big picture framework for what our hospital needs, right? And the services we can provide. So in total, as of 2020, there's a total of 21 active community advisory boards across the system, meaning majority of our systems and sites are do have a designated community advisory board. At Jacobi NCB, we do have two, even though we're one hospital, we did merge Jacobi North Central Bronx. We have kept the two advisory boards separate because our areas are different, right? The community we serve is very different from Jacobi and our Central Bronx, so we've kept it that way. Next slide. Perfect. So what are the role of the CABs, right? Again, they function as a bridge between the hospital facility and the community. They represent the views of the community and keep the community informed of the goals and objectives. So a great example of this is at North Central Bronx Hospital, we're undergoing a significant amount of construction, and we rely on our CAB members to let their community know, hey, our doors are still open, even though we have scaffolding, even though we have construction going in and out, that is not disrupting patient flow. We are still seeing patients, our ED is still flowing. And so we just allow our community advisory board members to be our advocates. They do serve on different committees. So we have an emergency medicine committee, we have membership committee, we have a community outreach committee, we have a patient care experience committee. There's so many committees based off of your interests and engagement level that you can be a part of. As Angie mentioned, our advisory board meet monthly with hospital leadership. So all of our senior executive leadership team is in attendance. It is our opportunity and their opportunity to connect with our senior leaders, which is really lovely. That's pretty rare. Our CEO makes every meeting. And we have our other officers that are very involved, and they typically do present. We also give presentations once a month from different departments within our services at health and hospital. So like today, we had harm reduction. Last week, we had the dental team, the chair of dental present. All right, next slide, please. So these are our acute care sites. So again, in the Bronx, you have Lincoln, Jacobi, and North Central Bronx. Lincoln is in the South Bronx. Jacobi North Central is in the north part of the Bronx, northeast. In Manhattan, we have Bellevue on First Ave. We have Metropolitan, right? And we have Harlem. In Brooklyn, we have Coney Island, Kings County, and Woodhull. And in Queens, we have Elmhurst and Queens Hospital. Next slide, please. And then we have our long-term care sites. So that is Carter, Kohler, Gouverneur, McKinney, and Seaview. So these are the places that require just a little bit more senior care, more attentive care, right? Those are typically our skilled facilities as well. And then we have our Gotham sites. So these act almost as a clinic in a way. So you can think of it in that aspect. Whereas the hospitals, the acute sites function fully as a hospital with an emergency room and our level 1 trauma centers. And they also have the ambulatory care space, the clinical space for outpatient services. So inpatient and outpatient at the hospital. On the acute side, on the Gotham side, it is only outpatient. Next slide, please. All right, so our community advisory board does operate under our bylaws. We call this the MOU, Memorandum of Understanding, and essentially outlines the CAB system and structure. Next slide, please. Next slide. So our purpose of the Community Advisory Board, right, is to understand the views of the community and how the hospital is making their decision, right? How is, for example, how is the construction at North Central Bronx going to affect the community, right? And what does the community need? And how can we better service public health? So I love this work because public health is my background and I get to apply what I've learned so much in public health and to really understand, right, the community's needs and their wants and their engagement, right? Then there's the advocacy component. How can we strengthen this public health system, right? Through investment, through support. And investment doesn't always look like financial, right? I just talked about the blood bank. That's a great way to invest into the hospital, right? Will you keep this facility funding a priority? Someone mentioned about federal cuts earlier, right? That was an excellent question. Does the impact of federal legislation impact our hospital and how, right? And this is where we connect with our local elected officials a lot. So it's really lovely to be able to do that. We host a legislative breakfast in February where we bring our elected officials to the hospital, and our CAB puts this on where it's their opportunity to ask our legislative electeds, right, on what it is that we need for the hospital and what does the CAB need. And then awareness. So again, spreading that information. We do conversations like this on WebEx, on Zoom, in person. We'll have meetings. We'll go to different organizations, right? And talk about these public health issues, right? Talk about what's available to them. Because a lot of times people don't know, right? How will you see our programs, right? Sometimes I might think that, oh, yes, it's very beneficial to post our work on LinkedIn, but also not everyone's on LinkedIn. So our CAB helps us to understand where the needs are of our community. And I can tell you all confidently that looks very different. What Community Board 8 needs is going to look very different than what Community Board 11 needs or what Community Board 5 needs, right? So this is why we have these conversations. And I'd love to get from you all what is it that you need from us. Next slide, please.
The part of putting this out there is that why this.
Sorry, is that a question? Nope. Okay. So again, just really quick advisory. I'm not going to go into full extension of this, but our overall goal is to focus on systemic change and think of it long term, right? What is working in the facility? What can we fix in the facility? And what can we do better to improve overall patient care, right? And our advisory doesn't necessarily mean being hostile towards staff or to patients. And I think that a lot of times we have folks who may join the board because they are interested in something else, right? And that's okay. But we also have to remember that the purpose of our community advisory board is to support the hospital, Jacobi NCB, and the surrounding area, and overall the patients that are there. And that's the main focus there. Next slide. Okay, so this is the advocacy that I was talking about, and I want to break down this further. So we do have an advocacy division within Health and Hospitals, and they help us to advocate for our needs. So our lovely Michelle DeBacco goes up to Albany almost every week, and she is engaged in advocating for our health and hospital system as a whole. On the CAB level, there's still the ability to do that. So we do have an advocacy day, which is usually around mid-February. So at the federal level, we can write to our president, our state senate, our Congress. At the state level, the governor, the state senate, the assembly. This is where we mainly see our CAB engagement at the state and local level. Doing the outreach to the council members, the assembly people, the borough president's office, and the mayor. Next slide, please. So awareness, what can you do? So it's to help us share our resources, right? Tell everyone. So one of the unique things about the CAB is that you only have to live, work, or receive services in the Bronx. You have to be over 18 years old, right? And you have to have the ability to, go through certain screenings, health screenings, and background checks, right? But look, you may not live here, right? You could be living in Long Island, but you're a patient of a health facility in the Bronx, you can still qualify. So I think that's really unique, because a lot of these programs have, certain criteria that you have to live in our zip code of the hospital. That's not the case. We'll take anyone as long as you fit that criteria. So again, you can share this information with your community meetings, partner with groups, host events, or simply just give updates. And that's what our CAB does. Next slide. Next slide. All right, so this just talks about what our community advisory board looks like. I think this is really great for you all to think about. So the community membership consists of a community representative, a consumer, someone from the New York City Community Planning Board, a non-managerial employee rep. So we do have an employee rep, and then an ex officio. So we also have a patient rep as well. That is part of the community advisory board. Next slide. So just quickly going to go through this. So the consumer is about 51% of the membership. The employee representative is only one person who's an employee, and they cannot sit in a managerial title. They do not have, they're not allowed, they can vote, but they don't receive any other incentives from the CAB. So they are simply there to just listen and take the feedback back. And then all the other appointments come from the chief executive officer, the medical director or director of nursing, and then or general community involvement. And then our next slide, please. Our Bronx Borough president, I think it should talk it. No, but I'll share it here. So our Bronx Borough president also appoints community members. And so if you all have ever seen from the BP's office, she'll share like a community board application interest. Usually she pulls from that application to assign or appoint folks who are interested in the community advisory board. So I would say if you're interested, you can directly apply with us, or you can apply within the Bronx Borough President's community board application, and then she can she'll let us know who applied. Very quick, I don't want to go over time any longer. The term of appointment here is 3 2-year terms. They can't exceed a total of 6 years. So essentially you do your 2 years, you take a break, 1 year off, you go back 2 years, you take a break, 1 year off, and then you can go back. And then after that, you would be at 6 years. So that's a little bit about the work we do. We can have up to 27 people. And then all CAB members do have to go through the formal HR process. So they do get a background check screening, same as we do for our volunteers. Next slide. That should be it. This is just again, so here we go. Yeah. So our borough president appoints 9 people. 18 is appointed by our CEO. And then the representation should encompass 1 consumer, 12 community reps, and then the employee one employee representative. The consumer reps is 14, and then the community rep is 12. Next slide. That should cover us. So just general conflict of interest. If they're an employee and they have a supervisory position, they cannot be in the CAB. So for example, I cannot be in the CAB because I'm a supervisor. Members of the CABs are, if they're employed by a vendor, so if they're a vendor within our system, they can't be a CAB member because it's a conflict of interest. But we go through all of that if you are interested, and if you have any conflicts, we'll work with you to see what it is. Next slide. All right, so I'll skip through this, but the gist of the rest of the presentation talks about the individual roles of the officer. So that's a little bit more in length, but we do have a chair, we have a vice chair, we have a second vice chair, and a secretary. So those are the 4 positions that we have that govern the CAB. Otherwise, I think it's okay to pause there. The rest talks about the role, attending the meetings, presenting the community with the updates, and that's the gist. This slide can definitely be shared if you'd like. I can share it with you all, but I'll pause for questions. I don't know if Angie had to leave the office space, but I'm here to answer any questions. And I used to sit in Angie's role, so I used to be the CAB liaison before I was promoted. So I'm happy to answer questions in her absence.
Any other questions?
It sounds wonderful.
Thank you. Yeah,
Thank
that's,
you.
that's fantastic, and thank you for
Thank
such
Very
a
professional.
thorough presentation. And I'm sure that the community would certainly it would be nice for the community to be aware of that, and we'll be sure that this information is disseminated.
Thank you. And I'll just share Angie's email so that you all have it. It is Teran, TERAN as in Nancy, A as in Apple, NYCHHC.org. And you can always reach out to her to any questions. If folks you would like to come and visit and tour Jacoby NCB, we'd be happy to arrange that as well. And any CAB related questions, you can always give Angie a call. It is best to email us, but I will give my office number. We are mobile between Jacoby and NCB, so always on the go. I'm actually across 3 different sites, Jacoby, NCB, and our downtown office, central office. So email's best for me, but my phone number is 718-515-1565. Again, 718-515-1565. If I don't answer, it just means I'm not in my office. Please leave a voicemail. I will return your call, and I'll be happy to connect with you all. Thank you again so much for your time and for your questions. We really appreciate it.
Thank you. Thank you so much. All right. With that, I would like to go back to item number 2. Since we do have quorum now, to go over the minutes. We are going to act on the minutes from April 8th, as well as from, and then approving the minutes from March as well. The board members had the opportunity to review the minutes from March 5th, 2026 and April 8th, 2026.
I've read them. I'm not sure I can vote on the April meeting because I was not there. But I was at the March meeting. Moved to approve.
To do it, but not be at the meeting, does not prohibit you from participating in the vote.
Exactly. I was just going to say, you
still
could still
Yeah,
vote.
vote, you're allowed to vote.
Yeah.
You do what your conscience says, just, I used to do
My
the same
conscience is fine because based on discussions with you and Dr. G, in fact, I think I reported to the full board and I was. I move that we approve.
We vote on these in the.
Yes. Second. Right. All those in favor? All those who said. Okay. All right. Minutes have been approved. All right. So I'm not going to ignore the elephant in the room because we got a lot of popular people here today. So up top, the next topic is discussion of resolutions. I'll start with the resolution in support of universal health coverage legislation in the state. This is just a skeleton. I just wanted to make sure that there was a framework there. And we can talk a little bit about the items that we would like to see in a resolution supporting. This is not official. This is just for discussion.
The document we're referencing is not for distribution because they haven't finalized the document, so we can't give anything out yet.
Right. Yep.
Yeah, I have a copy.
Good. But that being said, I do believe that there are members of the community and other members of the board who are have some significant concerns regarding healthcare in general, as well as the legislation that had been put forward as of last year. As it stands, unless something happens in the 11th hour. I don't believe anything's going to be introduced this session.
Well, the bill has been introduced. We were talking about the
New York Health, yeah.
the New York Health Act. The bill has been introduced in both houses. It has not been brought to the floor of either house. There have been no public hearing on it, as best I can determine, and I've spoken to staff people. Nor, as of the last conversation a couple of weeks ago, is there a plan to hold hearings between now and the end of the session on or about June 30th? As far as I know, despite the governor's announcement earlier in the week, there has not been an approved state budget yet, much less taking on something of this magnitude. It likely will be reintroduced in both houses for the next session. It's conceivable there could be a session after the summer recess in the fall. But based on my conversation with staff people, the one new element for the discussion is the formation of the committee to promote the New York Health Act. And excuse me if I forget the name of it, but they have recently launched a website, several meetings in Albany to promote the bill. I can't tell you any more about it because I haven't been able to find out anything more about it. I don't know who's in it. Both bills, well, the bills in both houses are identical. We're talking about one bill. Assembly numbers, they are incredibly confusing. Questions concerning the implementation would take up more than this committee has time to submit to me. These bills have been coming for 18 years, I think, since they were
34.
Yeah, right? Since they were first introduced by Dick Gottfried, who was one of the giants of healthcare legislation in New York State over his tenure in Albany. They've been reintroduced every year since without any movement. There seems to be increased interest in it at this point. I can't speak for the committee, but our brief discussions on it today, I think it's safe to say, and Wayne can contradict me, we are certainly in favor of some kind of improvement in healthcare costs and expenses. Whether this bill meets that or not. I've been working in healthcare since 1990 at the Health and Hospitals Corporation, at the New York City Health Department, at a Medicaid managed care company, and at Montefiore Hospital. And gone through 30-something pages of this bill, plus a couple of times, and I can't answer a lot of the questions that come to my mind. Yeah. But we're certainly interested in hearing from the community, and we will continue our discussion, leading potentially up to a resolution. One thing about the resolution, by the way, even if we were to pass this draft tonight, it has to go before the full board. The next meeting, the full board is the 24th of June, and then we're off for the summer. Maybe you can tell us whether we will continue to work on it, present something to the full board next month, or until.
Right. So, I mean, first things first, I think I'd like to definitely thank Steve on all the work that you've done. I think we're certainly fortunate that we landed a healthcare and policy wonk, and so and we haven't driven yet. And
This one might.
So it's definitely been helpful and handy, and I definitely do. I'll say at the top of my head, from the bottom of my heart, I appreciate the work that you've been able to put in to this, because again, this is a complex issue. I think that the consensus before we start any fires here is only Billy Joe gets to do that. But I think what we have discussed, yeah, the jokes will keep coming. But I think one of the things that we have hashed out from the first time that we heard Senator Rivera talk about this, and I think given we have a lot of people, almost everyone in the committee is in healthcare in some way, shape, or form, but I think we all agree something needs to be done. And that being said, whether it's this or something else, I can't say to that, right? Like I can't say if the New York Health Act as it exists is all things to all people. I think we recognize that in these multiple iterations, since it's almost old enough to drive and have a mortgage, that it's definitely started to address more of the concerns, but it's not perfect. And I think our feeling was that as a committee, we need to, something needs to be done. And whether it's this or something else, I think we need to show how I think we as a committee feel, and also as how the community feels. And I think in doing so, it's also important that we articulate not only our feelings about this, but also addressing the very real and the very legitimate concerns that many members of the community have. Because I think while the enemy of good is better, and you do have to start somewhere, I think that you stand the best chance of success if you make sure that you address as many real concerns at the beginning, rather than trying to kind of do things hodgepodge. And so I think the purpose of this is twofold. Is one, to make sure that our feelings are known, and also to make sure that I think there's a degree of engagement in the community. I think that, surprising to a lot of us, the first time I heard, Senator Rivera speak about this, I was like, oh, this exists. And it's existed for a while, really. And so I think that we're not going to get anywhere unless we either, one, let them know the real concerns that exist, and then also make sure that the community at large knows that this thing is out there. And then at that point, we can definitely make some sort of headway. This is, like I said, a skeleton. It's not the defined thing. But I did want to make sure that there was a framework, and I did try to make sure that we started talking about, I think there were some very real legitimate concerns that many members of the community had. I think Ms. Walter in particular had talked about, obviously, in terms of, again, one, do we have any evidence that universal single payer works? What are we going to do? How does that work? How does this impact a lot of other stakeholders like unions? Is there going to be, what issues are we going to do in terms of addressing patient choice and access? What assurance do we have that the decisions that are being made in terms of medications and resources and procedures are being done with the patient's best interest, as opposed to profit or other insane points of view. So with that, I know that there are many people in the community who are very much interested and at least want to start, and they can take the floor and start talking about some of these issues. Ms.
I'd
Kern.
like to take the floor and start.
Ms. Kern.
The first concern you mentioned is something about how do we know, that, I think, did you use the term single payer?
Single payer, yes. Right.
How do we know that this is workable? The United States pays double the healthcare of any other industrialized country in the world.
And we have some of the worst outcomes.
And we have the worst outcomes of the industrialized nations. And every European country, Australia, Japan, New Zealand, Taiwan, all of them have universal single payer plans. Some of them also have some private industry, some private for-profit things for peripheral services, but every single country, other than the United, we are the outlier. We are the only country that does not provide universal health care for us. That was concern number one. Is there another concern that perhaps I could address?
Look, I'm simply articulating. I think the important thing is, because again, this is not going to be Wayne's document.
No.
But I do think it is important to, and now the version of the bill that does exist has, and I think Senator Vera, when he spoke of this, did talk about those same points. But I think it is important that we, in writing a resolution, make sure that we address concerns and talk about what is out there. So you're preaching to the part in that regard. But I'm just making sure that what we put on paper as a committee is reflective on the whole.
Well, there is new information. On Monday, I was at a press release of a white paper put together by two scholars who are expert in health economics. And what they did was use actual data and study the impact on counties, municipalities, and school districts if we were to implement the New York Health Act. What they took the actual budget of the counties. They did big counties, little counties, various in different parts of the state, and the actual amount that those counties spent in their budgets on healthcare for their employees. That's their teachers, their maintenance people, their security people, and so on. They took that figure, then they took the actual salaries of the workers in those counties and slotted them into the progressive taxation scheme that has been proposed in the Rand Corporation study and in the Amherst study and so on. And measured that against what the counties and school districts and municipalities are spending in fact. What they found was that at the county level, were the Health Act to be implemented, the counties would save between 90 and 95% of the money they're spending on healthcare. What they're doing now, of course, is they have to buy private insurance, for-profit insurance. And they have no ability to control the pricing for any of that.
Mhm.
And it's only going to go up, as it is for us. I mean, we're all facing increases. The trend is simply going up, and we don't really have any way to fight that with the insurance companies.
Mhm.
So the difference, now if we realize that most of the money that these entities throughout the state pay these costs with is property tax. And the difference that it would make in most cases, at the county level, certainly, it would mean they do not have to raise property taxes to meet those costs. If you're saving 95% of what you've been spending, it's enormous. It's 17 at the county level, it is 17% of their budget. One of the legislators sitting at the table as they went through this looked up and said, the savings are astronomical. At the municipality level, no matter what the size of the municipality, from the largest to the smallest, the savings range between 80 and 85% of their debt.
So,
And similar with the school districts. And this was consistent throughout their data, consistent throughout the state, and they're using actual numbers.
so what I'm hearing from you is that, at least based off of the methodology utilized, large estimates of savings. And so, and again, we can also, we can certainly argue that in modern healthcare, the administrative state has grown exponentially over the past 50 years. And therefore, by eliminating some of that, that can certainly reduce some of the costs. And so I think that some element of the financing and the cost savings is certainly something that would be prudent to add as part of the resolution.
I'd like to point out that on June 3rd, there will be a public presentation that you can all listen to on Zoom. And I will get the registration information if you're interested.
Thank you. Appreciate that.
On their website, I tried this morning and couldn't manage to register for it.
So,
New York Health Act.org or something like that. NY Health Act. NY Health.
NYH campaign.
You know who's in back of that organization?
Melanie DeRigo is the executive director of the organization. She is in coalition with Physicians for National Health Program, New York Metro. A group called Our Bronx, which is a very established, they are formally known as the Northwest Bronx Community Mental Coalition. They are in allyship with NIPAN. I'm a member of all of them.
Yeah, now, I'm curious who's funding them. Are all these organizations contributing to whatever costs are associated with their activities so far?
To some degree, I know that I know our Bronx does.
I don't ask that question with any kind of prejudice. I ask it out of curiosity. This organization, all of a sudden, 3 weeks ago, I think, when I first became aware of it.
This is not this is not 3 weeks
ago. No, but the website, I think, launched relatively recently because I've been circulating.
That's the new website.
New website, okay. I've been circulating.
I joined the organization 10 years ago. So this organization has been in existence. They went through a period when they did not have enough funding for an executive director. I know that I contribute on a monthly basis, and I'm sure many other people do. What Melanie has done is establish volunteer hubs all over the state. And working with Indivisible, which is important to me. I'm on the steering committee of the Northwest Bronx Indivisible. We're beginning to coordinate the educational activities, the lobbying activities, and our grassroots movement is developing. We're not there yet, but we are definitely expanding. And the economic data, now New York City does not operate on the county level in the same way that the rest of the state does. So the white paper results apply to most of the state. But within New York City, the projected shortfall for budget in 2027 is $10.4 billion. That's what we're facing next year.
So,
all right.
So I think that with that said, I think, like I said, we're not necessarily directly supporting this act itself, but I do think that irrespective of what program comes about, I think it is important to articulate the benefits of the cost, the strong benefits and cost savings, and obviously removing a not a for-profit entity. And so I think some of those points can certainly be added.
When your language in the minutes from the last meeting that I missed, I think is entirely appropriate for the conversation.
Yeah.
There has been someone waiting to
Right.
speak online for quite a few moments now, and I just want to make sure we're letting people physically in the room and those who couldn't be here
Right.
both at time.
Yeah, and yeah, we're going to address that. But yes, I think one of the things that we did talk about last time was again, and I think the key thing here is because again, our goal is not to. And Ms. Fletcher, we'll have you speak in a moment. I think right now, the important thing is talking about the underlying principles, right? Because again, I think if we simply say, I don't think we necessarily want to throw our hat in the ring and say we support this specifically, right? Warts and all. But I do think that it is important that we articulate the elements that we like, the elements that we don't like, such that we can. And I think the idea was we want to get the ball moving, and we want to say something should be done. And so, but that being said, I think cost savings is going to be an important part of any discussion on this. So,
and I would like to hear more about the concerns.
Yeah. All right, Ms. Fletcher, your hand's been raised for a long time, so please go ahead.
Thank you. I want to bring up a few things about the bill. It's not a new bill. It's been around for 30 years. And it's been revised and perfected throughout that time. I became aware of it about 9 years ago, and I've read it 3 times as it's been revised. They've been given many concerns, the kinds you're talking about, and have continuously made it better and better. including for the unions. They made all kinds of adjustments to have better representation by the doctors. The doctors can negotiate their rates. They'll get more than they do for Medicare patients, and everyone will be covered. So they've made a lot of accommodations and improvements over time. I think it's good to go as it is. It's ready to go. I think that people who might lose power or profits, like insurance companies, might oppose it, or some of the unions, many unions support it. The ones where they can control their members by not having health care established might feel their power threatened, but the bill has been changed to fix the concerns of the union membership. I want to also mention Riverdale has a lot of our 8th community group.
Community Board 8, thank you.
I'm sorry, I'm a senior and I forget things. My biggest concern, we have tons of seniors in Riverdale, and I've had good health care, I have good Medicare, but I was very unhappy with insurance-based health care. My biggest concern is losing everything if my husband and or I develop a need for long-term care. And one of the most compelling things to me in this bill is that long-term care would be covered. And even the best union plans don't do that. And because it saves so much money other places, it has enough money to do that. I also want to point out that in the face of HR 1, people are going, and the non-renewal of ACA helps, people are losing their insurance right and left. So we're not just comparing this with the status quo, we're comparing this, it would protect us from the federal government's heinous eliminations of protections for people. People are already dying because of inadequate care and insurance denials, Medicare Advantage being a privatization of Medicare. So even Medicare is at risk. The federal government has been trying to privatize Medicare for years. I also want to and so this is to me absolutely essential. And it's been perfected so many times, nothing's perfect, but it's a bill ready to go that's been worked on by really responsible people for many years and made better and better. And the last thing I want to mention is, in addition to these recent analyses financially, for years, even the Rand Corporation, which is quite conservative, as I understand, have their studies have indicated that we would save money on this system, that at least 95% of individuals would pay less in this state, and everyone would be covered, including people who work here full time. So these are just a few of the things. I would like to ask if Helen could give you the websites for the Campaign for New York Health, and especially for the Physicians for a National Health Plan Metro, because there's a set of resources that address, I can't imagine they won't address everything you've thought of. They have position papers and descriptions on maybe 10 or 15 aspects of the bill and how it would affect different constituents. So I would urge you to please look at those, because you'll learn a lot about the bill through those.
Thank you so much.
Okay, thank you. And thank you for welcoming this discussion. I want to say that I'm a retired teacher, a member of the United Federation of Teachers. My union does not support this. And of course, it piqued my interest. As you know, I've been coming to the last 2 meetings. If this has started since 1992, and why hasn't it progressed? What have been the issues, and why doesn't most of the public unions support? I know there are some that do, but well, first I started my research with the RAND study, and which is educational. And then I also sent this committee the FREOPP, the FREOP report, which stands for the Foundation for Research in Equal Opportunity. And, you know, I'm going to try to synthesize the research and my concerns. Okay, first, I want to bring up that Vermont was the first state, the only state to implement the single payer. And they started in 2011 and ended it in 2014 because it was unfeasible. I have these articles, I can send them tomorrow, because I think New York must read the autopsy of why it failed. One article, The Demise of Vermont's Single Payer Plan, 6 reasons why Vermont's single payer health plan was doomed from the start. It was published right after it failed, and the governor, the Democratic governor who started, it said that the potential economic disruption and risks would be too great for small businesses, working families, and the state's economy. They hired people from Harvard, the top economists, health economists, brain trust, and they swore costs would go down. It increased by billions. And there was a very thorough autopsy as to what happened. And I'm reading it, and I also read the bill, which very complex. I saw the same situation and some of the same language. So we have to take a lesson from that. This whole concept, of course, healthcare and improving healthcare is very well meaning, but the devil is in the details. And we have to understand that this act deconstructs the entire healthcare system in New York State, which is 1/5 of the economy. And the studies that I read, I will just share, what I learned. My first concern is that this is unaffordable. The Rand Corporation study, which is often cited because they're supportive of the legislation, found that implementing a single-payer healthcare system funded by payroll taxes by employers and employees would require at least $210 billion in new taxes. That's the Rand report when fully implemented. Rand did not include the cost of long-term care benefits, which would require an additional $40 billion in taxes. Now, I gasped when I read that this is 3 times more than what New York State currently collects to pay for everything from schools to roads to bridges. Now, having looked at that, what I sent you after last month's meeting from the Foundation for Research on Equal Opportunity, their whole report was an analysis of the Rand report. And they point out several flawed assumptions. One, they said the Rand authors wrongly assumed that economic growth in New York State from 2022 to 2031 will be identical to what happened here from 1997 to 2017. So their report, Rand report is 8 years old. Their data was, of course, older. Conditions in New York State have changed drastically. But yet, while they also still say that the state's tax burden is going to triple. But what's happened in the past few years is that we've lost many corporations, businesses, wealthy people. And that is a fact, and that is continuing to happen. So their flawed baseline projection fails to account for the real impacts of outmigration of high earners, imposing a higher tax burden on those who remain. Yet the Rand study acknowledges that any reduction of tax collections from the highest income people will require higher taxes on lower and middle class people to make up the shortfall. And in fact, This study is done by the Foundation for Research on Equal Opportunity. They specialize in, when I researched them, they're nonpartisan and they're looking at lower level impacts. All right, so then there's the cost. And then it's my concern about Medicare. We pay into Medicare and Social Security. And to me, a troubling aspect of the legislation is that it seeks questionable federal waivers and approvals so that New York State can access the funds from Medicare, Medicaid, Child Health Plus, the Affordable Care Act, and everything else. So it's questionable that they will even get this waiver. And they say if they can't get the waiver, they'll do something else, but they don't say what that something else is. And they need to access our Medicare and Medicaid and everything else in order to provide directly to healthcare providers or their newly established bureaucracy, the trust fund, which is, 30 some odd people in all different fields appointed by the electeds and whatnot. And it's very, very vague. It's very troubling to me. And if the state, like I said, if they don't get the waivers, and that's, what's going to happen there. Now, there's something else that this report pointed out. There's going to be inevitable lawsuits, and that's based on federal law and Employee Retirement Income Security Act, known as ERISA, E-R-I-S-A, which is the basis for providing Medicare Advantage plans and employers' use of private insurance for their workers. And that's a law that this report was saying you can't get around that law that's giving them the right. There's going to be lawsuits. This report estimates that the New York Health Act will result in the loss of 315,000 jobs in insurance in different agencies, that this is an unprecedented expansion of subsidies. So they're increasing to all people in New York and as well as people out of state who work in New York, full-time or part-time. So the scope of the whole precedent is just something very, very new. And I mean, I'm also active in the group, the New York City Organization of Public Service Retirees. We're all familiar with them. They have 3 lawsuits. We all contribute funds because they're fighting New York City for their traditional Medicare. So they don't want New York City to mess with our Medicare. And I'm concerned about New York State messing with my Medicare. I don't want Congress messing with my Medicare. I don't want the president messing with my Medicare. We have earned it. We have paid for it. And this, these are some of the troubling things. But again, I started with Vermont, what happened. Sure. And I think I'll send you, there's many. And these people were the most brilliant people. They were the ones who formed the Affordable Care Act. They were behind this. They swore that prices will go down, et cetera, et cetera. That did not happen. And so therefore, we have to really be skeptical. And that's just, those are my concerns.
Okay. So thank you for that. So I'm going to bifurcate that into 2 things, right? So you spoke specifically of things that are concerns regarding the New York Health Act. Mm-hmm. And in light of the fact that this is a broad support of some form of universal health care, I would like to distill some of your comments to something that can fit into a resolution. So that's part of it. The other part, I think, are all very specific things that when and if, and I'm sure he will come back again, that Senator Rivera comes back, I think we can kind of make sure that those specific points are brought to him. Only because, again, if we're talking about healthcare as a general resolution on healthcare, to attack points that are made specifically by regarding the New York Health Act, I think would not necessarily fit. But that being said, the essence of what you're saying, I do think are things that need to be mentioned, right? So, irrespective of what,
I can send you my notes.
No, I believe, please. So obviously, like,
This
again,
is one thing important that I
Yes.
left out and I have to.
so like you said, job loss. Job loss is something that's going to be real, whether it's the New York Health Act or any other form of healthcare. So that's something that definitely should be articulated in the resolution. I think that that if we are looking, and while we do have the challenge that we have, right, is that we have examples from other parts of the industrialized world with the understanding that we are special and we are different. So
England come to America for an operation.
Yeah, no.
They cannot even get it in.
Right, no,
England.
and right,
It's
so-
2-year waiting
so
list.
that's it.
So I'm not impressed with other countries.
So there's no perfect analog, right? And so we cannot imprint another country's system wholesale onto us. That being said, it is important to note that if other people, again, if everyone else can do it, why can't we, right? So that's important too. But I think that we have a case study, and so I think that what I propose that we stay in this resolution is it is critically important that we look at failed models to understand where they went wrong and ensure that whatever goes forward at some point or sometime before I retire, whatever goes forward takes those things into account. And I think that distilling it, I think Vermont is a very important point to make sure that whatever we say is included in
And
that.
New York would be the first because none of the states have it.
Correct.
So it's
Right.
not implemented anywhere. And that's why the autopsy on this that they're doing, and they have been doing for years, interesting. But one point I forgot also is that my sister was a federal worker. I know a lot of people who are concerned because they have health plans that are federal or veterans have their own health plans. And when I read this report, it gave like 2 lines for all these very complicated, important systems and said they don't have a plan for that. And after it's passed, then they will concentrate on a plan for veterans, for no fault, for federal workers, which also gave me pause because if this is supposed to be, why would there be a separate plan if you currently now are a federal worker and you love your health care and you have it? Why aren't they having the same thing that I'm going to have? I'm not a federal worker. In other words, it's like there was so much not explained in here. It just seems so unready. And
Right.
yet it's 34 years old.
Right. So again, I think splitting that into specific concerns regarding the New York Health Act, and also I think things that we would want to make sure that we say in a resolution specifically for healthcare. And so again, those are I think important points.
Dr. Lee, can I just clarify something because I don't know if everyone, I think we all know this, but I want to say the quiet part out loud, and I want the debate to continue, is that we want to draft a resolution that encompasses the entire community board's varied opinion. So this is not a matter of if this resolution is going to be for or against. So it's not like we're trying to encompass what we think are the very real benefits of what's being proposed with the very real concerns that folks have. So that's why I think Dr. Ethan is rephrasing things because he's trying to. Nobody wants to read a 16-page resolution. I couldn't get through. But that's why we're trying to kind of distill all of these very points. And for those of you who, my name's Julia. I'm sorry I came late, Dr. Gomez. This is our 3rd consecutive meeting about this. This has been something we've talked about, I think, since September.
Right.
So, we do want to take action on it, but our goal here is to get all of the varied points and try to distill them down to 2 or 3 sentences in a whereas clause so that what we present is balanced and representative of the whole community board, regardless of any of our individual or anyone in this individual stance.
And I think the points that were raised at the April meeting on this discussion
They're
are
kind of So I think
important.
right. I think the feelings were, I think there's general gestalt of kind of the things that we want to see and don't want to see. But I also wanted to make sure that we put it on paper. So,
You see, I like my private health insurance and I want to keep it.
I just did.
And I don't know how you're going to put that in your resolution. Okay, but
Very creative.
What kind of a hybrid?
Sorry, but I'll take your point because I think that but
I would like to speak, but I think somebody had their hand up first. Is that a hand?
oh no, that's just
It's just the point.
that's the
Okay,
point.
oh Jesus. It's been a long day.
And it was a long yesterday.
My name is Ed Green. I'm a community board member. I'm actually wearing 3 hats tonight. And this isn't a prop, by the way. I came from work. So, I'm a Transport Workers Union member, Local 100. We have over 43,000 members. What caught my attention about this, and I'm looking at your January 14th minutes when you had Senator Rivera here. I read your minutes. You have a summary of questions and answers to some of these questions. So I have a TW Local 100 opinion on this. I have a board opinion on this, which also coincides with my personal opinion on this. So I'm going to wear my TWU hat first because I did contact our political action committee for Transport Workers Union, and I spoke to the director, and we are not for this bill at all, and for various reasons. So first of all, we like our healthcare. I love my healthcare. It's terrific healthcare. We collectively bargained for this over the course of years, and in some cases, whether the union, there were givebacks. So this was a fight to get these benefits, and we have great benefits. We want to protect our existing benefits. The other is, it undermines our collective bargaining power, and that's one of the big things because that's going to affect our wages moving forward. That's a huge thing for us because if this goes to a single healthcare payer system, that healthcare is part of our collective bargaining agreement, and all of a sudden we lose a lot of leverage when it comes to wages and other aspects, safety issues with our job, everything. So I'll take off the Transport Workers Union hat for a minute and I'll go back to your minutes because I saw a few things in the minutes that kind of disturbed me at a personal level and as a board member also. So the main thing outside of the union stuff is that, it says in your minutes, single payer system, state of New York would be the payer. It's actually not true. The taxpayer is the payer. And this is taxpayer funded healthcare. And as has been mentioned in the meeting, the costs are potentially enormous. It also mentions in your minutes that, and I guess this is coming from Senator Rivera. I didn't watch the transcript. I'm reading
That's why I tried to sum.
No, great. You did a good job. You did a terrific job. You caught my attention. Maybe not in the way you expected, but so reduced costs would improve primary care. I could not think of a more ludicrous claim if I imagined one. Improved primary care. I've been on Medicaid. I have insurance. Earlier diagnosis, treatment of chronic conditions. There's no explanation how. I understand these are abbreviated, but I suppose they have some type of a plan for that because I know how the state operates. I know the DMV, you don't move quickly in the DMV and a lot of other places that the state is running. I'm one of these people that I'm not the biggest fan in the world of corporations, to put it mildly. However, as crazy as this sounds, as bad as they are, I actually trust them more than I trust the government to run healthcare. So there's other stuff, talking about the how the formulary is created, non-formulated, based on medical necessity. That's kind of insurance companies can use that claim too. Is it medically necessary? I've seen, I kind of dread the idea of the state making the decision whether something's medically necessary. That's, one of my bugaboos. And to kind of piggyback on that, in number 12, it says, how will you ensure that the question is, how will you ensure that federal dollars will be allocated appropriately towards citizens? I imagine that's the question you asked Senator Rivera. And number 2, state dollars can be spent any way the state deems appropriate. Wow. So that opens up all kinds of implications of, treating people based on their political ideology, religious creed, whatever you can imagine that the state has done to other societies in the past. This type of a setup, the possibility exists that could happen here as well. It always does, whether people want to admit it or not. It's happened. If you don't know that, you don't know your history. So I have a lot of concerns about this. And obviously, Laura mentioned she has friends from England that come running over here. Well, I know people in Canada that come over here because they don't want to wait 11 months for a procedure. But the bottom line is, I realize there are problems in the healthcare system. But speaking as a union member, and by the way, my political action committee director sent me about 5 pages of talking points. But don't worry, I'm not going to go into any of them. But I might save them for the full board if we have to go there. But so there's a lot of concerns. Our union is dead set against it, and I'll take that hat off and go personal because I'm not going to associate this with representing my union. But I would say any union that supports this is probably coming from their elected officers who have basically sold their rank and file out. That's all I'm saying about it.
So I mean, first off, I think, and again, I think this is one of the reasons why I think conversation is so important, because I think, and since it was January, right? Since January, I think you're the first person that I've actually heard talk about fear of loss of collective bargaining power, right? I think a lot of the discussion with the union has been, well, we've negotiated this. We worked hard for this. It's part of salary. We want to keep it, but the loss of collective bargaining power is something that has not been heard a lot, and I think is something that should be mentioned, right? And I think, again, irrespective, no matter what goes forward, is that the understanding is that it's not necessarily just I fought for this. It's the fact that now I can now also lose some leverage and some power. I think that I think as was mentioned, because I think we discussed that at that first meeting, there is concern, right? There is legitimate concern about who defines medical necessity, because I've probably swore at several prior auth people, but I haven't sworn. It's recorded, but that being said, I think that is also a legitimate concern, right? That I think no matter what proposal goes forward, and I would put that in the resolution that we want to ensure that there is an appropriate process for vetting of procedures and procedures, interventions, and medications, no matter what form of healthcare goes forward. And so I think those are things that I would propose adding to whatever resolution that we ultimately write.
The big question I have about this is who is going to set the rates that individual physicians, that clinical practices, and hospitals actually get paid. And what the network is going to be. And we all know, those of us in the field know the difficulty that health plans have with hospitals and hospitals have with health plans in terms of setting rates. And I can provide a rather thick file of studies and news stories showing the difference between the cost of routine procedures at hospitals in one part of our neighborhood and in another part of the neighborhood. And that is a function of how the current system works in terms of health plans wanting to work with lower cost hospitals, patients wanting special services, and Laura, you know this because you followed the issue with city government and the retirees. The first question that the city addressed, try to quell some of the complaints about it, was that Hospital for Special Surgery and Memorial Sloan Kettering were going to be included in the network. And those are the two arguably most expensive hospitals in the city, specialty hospitals. But the difference, and I can provide it to the committee, and I'd be happy to share that with anyone else, the difference in costs between hospitals just in the city for routine procedures is incredible. I mean, you're talking in some cases 3 and 4 times the cost of that. And Wayne, you know this, and Julie. The cost of a routine procedure can be $3,000 in one hospital and $12,000 in another hospital. That's 5 miles apart.
But you know, the Affordable Care Act didn't solve it, and the Medicare Advantage
the Affordable Care Act made insurance available to.
But here we are.
Right.
You know. In terms of a lot of the questions that have come up, which are very understandable concerns.
Please have somebody else let him speak because he's had his hand up for, and I would say something too, but okay.
Thank you. I'm a member of the community live across the street, and I've been involved in volunteering in this campaign for New York Healthcare Act for the past couple of years. I've heard many of the questions that have been raised. From my understanding of what the New York Healthcare Act is, there are not many plans. There is one plan. There is one plan for everybody, for the state, for the governor, or to the last person in the state. For everybody to have the same plan. There are not many plans. One thing. The second, when I'm a member of a union too. When the whole idea of bargaining suggests that you request something and you get what you can get. If you got something through bargaining, it suggests that you must have gotten less than what you wanted. That's logic. Now, in this case, union actually will end up more powerful because instead of cheaping out some of the healthcare benefit of their members, they cannot focus all the energy of negotiating better wages because the healthcare part will have been taken care of. That's common sense, in my view. Now, I have lived in a country where there was a single payment system. I've lived in a country where it was cheaper. Actually, even when I migrated in this country, my first year in this country, when I had an emergency, I had to take the plane, go to Europe, get it and come back. It would still be cheaper than the copayment. So I know what it is like. I know what it is like to live in a single payer system. And from what I've heard, from what I've learned in this plan, long-term care will be covered, preventive care will be covered. A society where preventive care is offered means less people are sick. The whole care system, the whole cost becomes cheaper. What makes our healthcare system more expensive, it is not the doctor, it is not the reimbursement by the providers and everything. It is the middle people. It is the people, all the stuff that are in between. And doctors will spend more time actually looking after the patient than calling the insurance company to figure out whether they can go ahead with the procedure or not. Doctors will be reimbursed. And that also, in terms of bargaining, the whole state, the government of New York will be the bargain on the other side. Any other provider, the server will have a higher bargaining power than any local union or any individual union or any individual organization. That's the principle of market. You want to do business in New York, this is what we're offering. And then you want to, there will be always somebody to offer the service in New York. So if the reimbursement will be there, then the whole point is that what costs more in healthcare are the intermediaries, are the middlemen. These are the ones who will be losing. It's not even that they won't be making any more money, but they won't just be making as much profit as they're making now. It is retiree or workers or unemployed don't have the same healthcare. There won't be any special care for retiree, and everybody will have the same care plan. So the plan that the governor will have is the same plan that you and I will have.
Thank you. Thank you. So, what is also very apparent is that we're going to have Senator Rivera back here again. But thank you to your points. And so,
I'm one of those 250,000 Medicare retirees who de Blasio tried to screw out of our health care. And it cost the city $8 billion. That's part of the indebtedness that the city has over that sleight of hand to take Medicare away from us, give it to Medicare Advantage, and allow the UFP to get raises. And it's all sorts of complex. And, like Laura said, the devil's in the details. Couple of things. Global health initiatives, who wrote part of that paper, are not exactly above reproach with who funds them. So I would look deeply in that. I'd also look deeply in their sleight of hand in the paper as to what, say, Suffolk County and the towns on the end of Long Island, and I pay them a lot of taxes, but I do live in Riverdale. What this savings is. Everybody talks about savings. It's just like the people who want to sell me a car. You're going to save money, but you're going to pay me. So that's how you're saving money. It's a sleight of hand. It sounds good. It's not true. It's definitely not true. So we have to look deeply. And yet, do things have to be better? In my job as a principal, Child Health Plus, I think it goes back to Happy, was miraculous. All of a sudden, because the federal government offered something and the state of New York took upon it, every kid in New York City and the state had health coverage. It worked. It was nice. I don't know how it was paid, but it was damn good when I had a kid with strep in my school and they got health insurance. It was done. And so what I'm saying is don't throw the baby out with the bathwater. 5% of the citizens of New York State don't have health insurance. It's 1 million people. It's a lot of people. There are 20 million people in New York State. Everybody else has health insurance. Maybe some is better than others. Maybe some people negotiate it better. But it seems that if you take Vermont, and I happened to have brought that up on my screen, that was going to cost $4.3 billion, according to the New England Journal of Medicine. The 600,000 people. There's something wrong with the scheme. And I don't think politicians should be doing it. I think you should be doing it, and I think people should be doing it. There are things that need to be done. But as my debate coach, who came from the University of Vermont, oddly enough, said, I think they're shooting a mouse with a cannon. You've got 1 million people who need health care. Figure out a way to give it to them without costing the entire state a lot of money. And I take objection to what you said. The United States has amazing health care. There may be some poor outcomes. We have amazing health care. We have world-class health care. My husband is alive today because of the amazing things that have happened. He's 86 years old, and we've got great hospitals, great health care. We've got a way to do this. And I have a feeling that if we allow politicians to decide how our health care is going to work, we're going to lose that. So here's what I'm going to ask in this. Your resolution should our resolution, because I am a community member.
You are.
Our resolution should say, we can't do anything until we get our questions answered. And the question they must answer is, how much is this going to cost? Global health initiatives can say you're going to save money. I happen to know a lot about Suffolk County and how those budgets work. Not going to happen. They're not going to give up. And the savings is not coming unless taxpayers are going to generate it. And whoever said this is taxpayer-generated healthcare, I'm so pleased that you're looking hard at this. And I beg you to be incredibly skeptical about the promises that Senator Rivera made, the members of the Assembly and the Senate, because I don't believe you need to do this to get health care for 5% of the population. And we keep lots of things work. Our Medicare works really, really nicely in New York City, at least in my experience with it. The cost for the supplementary plan for the 20% is about $200 a month. That's what the city pays for me to have a supplementary plan. So there's a lot of competition when you have a lot of people. And that competition can bring down costs. And I know I'm babbling, but please be skeptical and ask the questions. Don't agree to a resolution until you get the answers. How much is this going to cost? And our politicians never want to tell you the bottom line until they up your taxes. So anyway, thank you very much.
So what I hear in that, again, separating out things specific to the New York Health Act versus I think what we want to say globally. I think it's important that we talk about Child Health Plus as a model, and the benefits that it includes.
I don't know whether other people have.
It's not a perfect, but it is an example of how of a form of again global or universal care. I'm also hearing your concerns regarding Medicare as well, and so that's at least 2 votes for Medicare. So it's going to be important that we make sure that those elements are addressed. Medicare, and not just Medicare, but also with unions and any other stakeholder who has an existing investment in something, and kind of what happens with that. And then obviously the importance that this is not run by politicians, and that clinicians should have. Let's see.
Who it should be.
But there should definitely be right. So clinicians and other stakeholders should certainly have a sizable seat at the table, and I think that's something that I think.
Preventative models. Vermont is, like you said, is something to be studied, and it raises a lot of questions.
It's Bernie's state.
We have
Bernie Sanders
models in New York State.
Sure.
You know, the one that I know. You know, I don't know much about Medicaid, but I do know, a lot about Medicare, and maybe it shouldn't be one broad brush that paints everything. And it seems like all of these organizations that she spoke about are marshaling, and I wonder what their agenda is. It should be nuanced, and we should look closely at the 5% of people who don't have health care and give them something. And you know what? Great is the enemy of good. And you don't have to have the perfect thing, but you need to have something.
Okay.
I think a lot of the concerns that have been raised really relate to onboarding. The process by which the thing becomes real. And this 33-person commission that has representatives from unions and from the electeds and from the hospitals and from individual physicians and the various medical societies and so on and so forth are represented on this board. And they would be charged with studying what the final rates would be, and they would be negotiated. Now, the only state in the United States that has not had costs increase at the same rate as the whole country, which has been huge, is Delaware. And Delaware is the only state in the country that never deregulated the prices of medical care. They have a situation where hospitals and the politicians and the community, the interested parties, have to negotiate each year and set what the rates will be for the year. And that is a negotiation process. But they're the only ones that have managed to keep the costs down.
Hospitals do that now, like Mount Sinai and that now. They negotiate the costs and the reimbursement. Hospitals do that now.
They are negotiating with whom?
With
The insurance.
individuals.
The insurance
right?
companies. Yeah. And the insurance companies, their motivation is profit. They're in business.
And also, it makes a difference when a less powerful agent is negotiating than when a more powerful agent.
Negotiating in Delaware. What's the state in the insurance companies?
No, you're right.
So I think we're here debating the merits of a bill that none of us fully understand.
Exactly.
The purpose, we have been asked to consider a resolution in support of legislation. Our resolution will have no effect other than telling some politicians that we are generally in favor of the concept. I think over the last 5-6 months, we have heard sufficient amount of support for the general concept that we could try to draft a resolution that reported something other members of the board might approve. What we do here tonight, even if we were to vote on a resolution, goes before the full board. And I think what you heard a little bit tonight would be at the full board magnified.
Sure.
We spent several hours last night discussing something far simpler than this, with no conclusion. But I mean, I can't speak for the full committee. I can speak as a member. I think there is general interest in seeing if we can craft a resolution that would provide some level of opinion of this committee to take to the full board of our feeling about the need for some kind of reform of health insurance in the state. And I'll go one step farther, that what is driving this decision, this conversation didn't come out of the ether. It was brought to our attention by Senator Rivera, our state senator, who is the primary sponsor of the Senate bill. And I believe our Assembly members are signatories, sponsors of the Senate.
Right, correct.
In light of the time and the fact that there is one more agenda item that has to get done tonight, I would like to offer. Now, I don't think we're going to be able to write something tonight. I will offer to have something written by our next meeting because June is the only time in the entire year that we meet before the full board.
Right.
It just that and that other time we moved our meeting, but it's not supposed to. I will have something drafted for this committee before the next meeting so that we can try to fine tune that for submission.
Julia would be ready for exec.
Does it have to go to the exec?
Generally, resolutions that are serious.
I can't promise.
No, but you know what I'm saying, generally,
Yeah,
that's,
when's the executive?
it's the first
Executive
Wednesday.
before.
Yeah, I
Well, we
mean,
could bring it to the, we
Yeah,
could
but
bring it
I mean,
directly to the board.
Something like
Yeah,
this.
Yeah.
but I mean, I don't,
I don't think it could go to exec if it's not coming from the floor if the committee hasn't passed it procedurally. I think we have to pass it.
Oh, absolutely.
Yeah.
Right, our next meeting is going to be before the full board, but after exec. So I don't think, but if we get it passed in this, it can then go out with our minutes and we can try to get those out timely.
Sure,
I also
yeah.
volunteer to help.
Yeah.
So that it's distributed well before the full board meeting and everyone has.
Is there any time? Does it have to be done by then?
Yes, it's the way the board.
Right.
No, I mean.
Oh, this is gonna go for the 35th and 36th
Oh,
year.
well, we could start, okay. If it doesn't come before the full board on June 24th, then we're talking about
September.
Given a number and they
Right,
change.
right.
It'll probably be the same number.
I will say that internally, committee, I think we were committed to getting something out because we have spent the majority of this year debating
Right.
it.
Yeah.
And so,
And
but we can debate that again
Right.
next time.
And we
if you
can't
think this is
debate,
premature.
and we can't debate the bill, we can,
Right.
we can,
But I'd like to move that
Right.
forward, that I will
Right, right.
take the draft of the crack at drafting this for our next meeting if nothing changes, right? Cause I'm gonna say this and now something will happen tomorrow and everything's gonna go.
Right. May I just
Topsy-turvy.
make a comment about the 31 trustees that are appointed by the governor? When we were talking and saying, well, politicians and doctors, yes, you have many consumer advocates and you have rehab and you have mental health, you have all these people as part of these trustees, but there's only 2 who demonstrated expertise in healthcare finance. And I found that troubling. I mean, they represented a lot, and then they have 14 political recommendations by the Assembly Speaker, by the Senate, by the Minority Leader. This is still the core. The wheel is being run by politicians. Okay, and I just want to say that because
again, Dr. Warren, I want to send you some stuff, but I'm not gonna, perhaps local statistics that really shine a bit light on this.
Please send that to me too, the drafting of the.
Like I said, we're trying to thread the needle.
Just a second.
No, just you can say.
So just, I didn't get your name, that was awesome what you were saying earlier.
Deirdre.
Deirdre, you're talking about the 5% of the people that need healthcare. So these are actually statistics from the New York State Board of Labor and also from the RAND. But in the 81st Assembly District, which is local, if this bill were to, this is their statistics, so I don't know what they're basing it on, but it is the New York State Bureau of Labor Statistics. And if this bill were implemented, it would cost 8,229 jobs in the insurance and healthcare industry in just the 81st Assembly District. It would also cost $162,416,120. That would be higher taxes on the constituents, actually, just in the 81st district alone. That's $162,416,120, and also it states that 93.7% of constituents already have health insurance. So I guess they're saying, you say 5, they say 6.3.
Right.
We're in the same ballpark.
Yeah,
So-
I see 95. That's what I generally
Yeah.
see.
Well, in Manhattan, they have more.
This is
And
not,
this
this
is-
is not a
and
chemical,
the point I'm trying to make,
Assembly district either.
but the point I'm trying to make is, if we're making a resolution, this is for, I realize it's a much larger issue, but we should be focusing on our area and this is the Bronx Community Board 8 meeting after all. So how is this going to affect our particular area? And when you look at numbers like that, there certainly, in my eyes, doesn't seem to be a necessity for something like this when 93.7% of the people are already covered in healthcare.
By the way, this is a community board that defeated a resolution a number of years ago to allow Montefiore to open a multi-service clinic on Riverdale Avenue.
I don't remember that.
We talked about it every meeting, so I was on the board by then, so I know you were there.
Now it's an apartment building.
And now it is the largest apartment building
Right
in the community.
Yeah, that neighborhood, sorry.
I gotta find it.
But in the interest of time, I would like us to move on to our budget items, because those have to get done tonight. I wanna, I have no disrespect, I really appreciate everyone's thoughts, and, you're welcome to stay with the budget, but I understand our budgets are not, as quite as titillating as this has been along.
But that said, I do thank you because I think,
It's a great.
again, it's very good. And I think like I said, the whole point was to have a resolution that reflects the opinions and the concerns of this community. And I think whatever goes forward, whatever goes forward, I think those in charge need to know what our concerns are so that they avoid the minefields. And so, thank you for being here, and thank you for being and articulating your concerns. And we will definitely take all this into advisement when we compile something, because we will write something.
And I'll be there. When I don't lose my temper, I know I'm kind of
But thank you so much for
is it
everything.
temper? Oh, it's temper. I mean, it's very kind if you call it passion, but it's temper. It's fine. I know who I am. I'm all out there. Yeah, to be good for something.
Anybody who wants to, talk to me.
Sure.
I'm happy to give my email.
I'll take it, yeah.
Yeah, I'd be happy to do it. Helen.
Your turn? I thought you guys were.
Thank you all. Thank you all.
We're gonna be a slightly more intimate group.
Yes.
Thank you.
Thank you.
Thanks, guys.
With all your concerns,
Good
good
thing.
all these concerns.
Hang on to that material.
Yeah.
I'm kind of curious.
Good, thank you.
Maybe of the things you said of the rules. Addressing the debt. Relate everything to me.
Yes. Okay, so
I started this afternoon to see whether I could do something.
Thank you.
I was doing the State Department of Health on something else.
And.
Did you sign in? When you came in?
Yes.
Okay,
Yes.
no, just making sure.
Yeah.
Ellen, thank you
Thank you.
for coming and spending your evening.
Pleasure to meet you.
same.
Thank you.
I wish I had known about this set 8 months ago, and I would have been here to
I
answer.
think we'll probably have somebody, I think we're gonna, we'll see him again.
If you take a look at the minutes from last month, it states that the assemblyman, the senator and the council member, and maybe the assemblyman ought to consider convening.
We're trying
The
to have
person you really
town
need
hall.
is Dick Godfrey,
Right.
because Rivera's great, and he understands the concept and the larger picture, but on the, on the details, you need Dick Godfrey.
I believe
Miss Fletcher has a question still.
Fletcher, you have a question?
Yeah, I didn't want to keep talking and interrupting and taking more time, but I really feel I need to say a couple of things. One was just what Helen said. Dick Gottfried is an absolute expert at the bill. We've held several forums about the bill, and many of the questions, in fact, most of them that people were bringing up that were good questions, have been answered. I've heard them answered at these meetings. So I would urge you not to make a resolution until you understand the bill better, because I think there were a number of misconceptions and things that people, we've been told how Medicare would work with it. We were given the exact mechanism. We were told what would happen to people who lose their jobs. Virtually every point, a few not, but also even Vermont. The biggest reason we've been given that it didn't work is because they have a much smaller population.
Yeah.
We know, we've spoken this, like I said, we've had this on that camera. We let people speak their piece. We were not here to debate with folks about what we knew or didn't know. So I don't want you to think that this committee is ignorant of some of the
I see.
points to this thing. So that's why I propose we're going to table this. We will draft something. You're welcome to come back next month and then actually debate the language or something if you're so inclined. But at this point, we're not going to be able to draft a resolution we need to synthesize some of this. It's gonna take a little bit more
Right.
time, and there is something time sensitive we have to do before we can adjourn tonight.
I understand. I'm sorry
Yeah,
to take your
cameras
time.
are driving me nuts.
Thank you so much.
Sorry.
I don't know. how
Thank
that
you
works.
for the chance to speak.
Thank you. Thank you.
Have a good
Take care.
evening.
You
We're
too.
both-
Okay. All right. So
Steve, just so you know, I dug up something this afternoon when my third alarm to do something about budget items came up. I sent it, I think, in WhatsApp, because that was the only way I could get it out of my, I was able to pull from when I was chair of youth. It wasn't my budget proposal, but I think it was the master list or something, so we have some examples. Again, I think, so procedurally what happens is we propose some stuff, and then one of you guys gets to go to exec and the budget meetings and hash it out. I mean, in exec, they'll talk about some of the language and stuff, and then we debate the placement and everything else. So this is no means do we have to have a polished final project. But I do think, because Sebastian does kind of need these things.
right.
And I think we've kind of in principle agreed to the ideas. Like, I think we've agreed that we want to continue to advocate for more funding for domestic violence
Support.
supports. No, but again, I
Yeah,
think I do, and you guys, gentlemen, are free to ignore me, but I do think it helps if we're like, we would like
Absolutely.
money for an additional domestic violence officer at the 50th
Right.
precinct. We would like money for additional social workers, for the transitional housing, for DV services, something like, instead of saying more money for DV, if we have a more specific ask, it's more likely to get funded.
Sure. So I think the things that we I think are important would be. Oh no, yeah, in the minutes. That's what it is. I'm like, I remember writing this in detail, or kind of summing up what we thought. So I think budget priorities. I think going.
Just gotta actually get a pen to write. Keep going.
So going back to the budget priorities from the April minutes. So we talked about support for domestic violence survivors, specifically funding for additional funding for the 50th precinct, the domestic violence officer there.
I mean, I would assume.
Or another, yeah, they have.
We can confirm. I believe they have to have.
They have one, but
yeah, we can ask for another one, or increasing their training budget, or those are all ways to support the committee's traditional support. Increasing domestic violence. That might be a little more specific.
So we'll say increased training budget. So in regard to the domestic violence support.
And this is something that you might want to talk to Ed, since he works so
Yes.
closely with the police and as public safety. Increase DV officer
Budget
training
and
budget.
second officer.
Or additional. I don't know how many.
I think there's at least one, but yeah, additional. Mental health services. Mental health services. I think we have. I think we kind of agreed that it's not necessary. Yeah, I know. I need to. Yeah, it's not necessary.
Sorry, whoever's watching this recording, I get weird.
I think it's just us.
Yeah, well, it's still recording for
Right.
like the public, so
Right.
if you're watching this later, I'm sorry, I'm weird.
And this is going to be in the transcript. So mental health stuff. So I think we kind of agreed that we wouldn't necessarily be doing it, but that we would. I don't know, because I mean, obviously, we're looking at places like Mosaic and EHC. So I mean, they have the resources.
I think at one point we were talking about 988, right? So
Right.
we can put, and I don't know how kosher this is to say. So disclosure for the minutes, I am a DOHMH employee, but like advocating for a broader train or additional materials for 988 or a broad. I know they've like some things
Right.
on buses, additional.
So more. I'll say
What,
Right.
what we don't know, I think, at this point is what's going to happen with the mayor's, community safety department
Yeah.
or something like that? The getting social workers to respond to 911 calls.
Well, we already have BHERD, which is social workers and EMS. So again, that's something it's supporting the expansion of that, as opposed to some other initiatives, expanding mobile crisis teams throughout the
Yeah.
city. Like, again, we can get, or we can just kind of say more broadly, increasing 988's awareness or visibility through marketing, or, you know, I'm not sure if marketing's quite the right word.
It is.
Okay.
Promotion.
Promotion. And I guess the other question is, do we want to also say something like funding for like outreach, like fairs? You know, like, do they have resources to put there?
I mean, DOHMH does have a budget for that, and there are some teams, but again, that's if you don't know about them, then there's a disconnect there, right? Like, I was surprised that more folks weren't more familiar with 988. I work with them very closely, but also 988 is a national law, so that's probably not as at risk of any city administrative.
Well, 988 is supposed to be for suicide,
right?
So what the mayor is talking about is, instead of having uniformed police officers respond to calls of domestic violence or disturbed individuals, to have social workers, yes, or community workers of some sort.
That's partly built in already. So the Be Heard model, which is the social worker and EMS through FDNY, is linked into the 911 system. So when someone calls 911, roughly, because I haven't worked closely with them in a while, and the dispatcher is able to determine there isn't a threat to the team, instead of having police respond, they send the team without. Right. So that's what I'm saying. We could ask for increased funding or expansion of that program. Which is slightly different than a 988 is how you get other mobile crisis teams as well as the suicide prevention.
So I think there probably is a need for some kind of increased training or support for emergency services, EMT specifically. And one of my day job, is the project manager of an Alzheimer's clinic, state clinic, at Mount Vernon Einstein. And one of our neurologists, who is working with a city EMT, not as a patient, but a caregiver, said that he was told that the emergency services does not get full training for deal with dementia patients. And the doctor was going to explore it a little bit further with this individual before I reached out to. I worked with the Health and Hospice Corporation when HHC ran the ambulance service before it was transferred to. So, I mean, that's generally increasing funding for emergency response, I think, is appropriate.
And again, specifically around behavioral health crises so I have on my list, and I didn't write everything down, but under DV, increasing the DV officer training budget, an additional DV officer for mental health, increased 988 promotion, and increased training for EMTs regarding behavioral health crises. Did we want to do something about harm reduction?
Let's throw it in there.
Yeah.
So harm reduction. So I guess.
And that's specifically to substance abuse.
Correct.
Yeah. That's the way I've always used it. I guess that.
No, that's term. That's a term.
So I would say, and this is where this one gets a little more sensitive because it's still pretty stigmatized. But I think the one that is least likely to cause too much of a fuss is just to increase availability of Narcan and test strips. I think test strips might be.
Test strips is somewhat more controversial than Narcan, isn't it?
Yeah, but I kind of think I think it should be more palatable today than the syringe exchanges were back then. Like we have a model where it's like, okay, I didn't like it, but it did work,
right?
And I think also with everyone knows what fentanyl is. Right. Everybody has heard the horror stories about what happened when. They were smoking marijuana and it was laced and they didn't know, and then people can kind of personalize that to my kid, my cousin, my, so those would be my two proposals for that.
Have we heard anything else over I don't even remember some stuff. September. Have you heard anything else in terms of people coming to us?
To visit or to like present and stuff?
Yeah, I mean, even the Health and Hospital presentation didn't ask us for anything.
No, I
Yeah.
mean, I think my experience, and tell me if yours has been different, when I was on Health and Hospitals previously, is that people come here more to share information and treat it more like an information hub. Because they understand that our community especially will call the board office with like, I can't get, and then Farah can be like, oh, actually, Health and Hospitals does that. Let me give you this person's. Whereas I think traffic and transportation or land use, they're coming in and ask.
right.
And that's why they produce more resolutions.
Yeah.
I also, I think while the presentations are nice and when people want to do them, that's great. But it's also, it does double meeting time, right? Like, I mean, and there was a great presentation. They covered a ton even for when I was here, but it was an hour.
Yeah.
And that's why my personal thing is.
That was the same presentation that we had at last month's board. There was a presentation by someone from Jacoby, because I remember asking Farah whether we could get a copy of it. I think that was the presentation.
That might have been what happened.
Right? Okay. All right. So you're going to take a crack at.
I'm going to take a crack at it. I mean, as the comment as we were winding down a little bit, I do think it's in the interim. I think we as a committee should think about, do we have to take any action? I mean, I feel like we have been kicking this around that we should do something,
Right.
but also sometimes no answer is an answer, right? Like it's not going to move forward. Do we hold this in reserve until it's actually?
The one thing that I would suggest as a driver of this is that our state senator is the primary sponsor of the bill.
Right.
Yeah.
Right? I mean, just as last night, we sat around arguing the protest bill
Right.
because our council member was a
Right there.
prime sponsor.
Right.
Yeah.
So it's,
I mean, I would also like to propose here that like we spend some of June maybe planning next year. We decide not to go forward with a resolution, but at one point we kicked around hosting a town hall
Right.
kind of thing for folks to do that.
Right.
We may decide next month that, but then because of the break, we should decide, okay, we're going to shoot for November so that we hit the ground running again
Right.
in September.
Yeah.
Also, I assume that I forget, I know things that aren't common because I've been on the board now almost 10 years now, is that technically, we can meet over the summer, we take a break, but we do need permission to, if something happens, we can call a meeting, just putting that out there as well. Land use is usually the only one that may do that because.
because they have it,
Or
because there's a calendar on it. That's
Or
what
Ed.
that's what happened last night. with-
Public safety with the
Trump.
liquor license
Right.
and Dutchess,
Right.
like those sometimes.
Yeah.
So if something changes dramatically and we feel like we need to meet, we can ask to meet. It just still needs to be noticed, but just so. Yeah.
That's it. I think, yeah, like I said, I think they're talking about a town hall, but like I said, it may be a case where maybe we just kind of use next meeting to kind of just start mapping out kind of the lay of the land, what we want to do, and then because there are a lot of people who do want to talk. But I do think next meeting also the representative, there's the Green Book, essentially a Green Book of it's a kind of public health services for people of color. I think they're going to be coming, so we'll have a
Yeah, I thought they were going to be.
Yeah, I think they made it available for June. So we'll do that, and then I think we can start to kind of mapping out what.
And I think in the interim, it might be worth reaching out to Senator Rivera to kind
Right.
of feel like, what is it, like, do you have an ask for us? Right?
Well,
Like,
I think,
maybe a town hall.
I think his ask is give us a resolution in support. I'm not sure what that would do, but.
Well, a lot of times the resolutions are, I mean, and this is where it's a little more nebulous for me. It is to kind of encourage other electeds to get on board. It does seem like this has a lot of sponsors already, so it feels like this, unless, and I don't know all the players, unless there's someone that represents this area that maybe hasn't fully, that then sometimes it's like, listen, your constituents want this.
My belief is that this is an easy bill to sign on to.
in spirit.
Because it hasn't, it hadn't advanced much beyond the writing or rewriting and rewriting again over the last number of years. I would strongly recommend that no strong position be taken, at least until there are actual hearings on it.
And I think that's the concern.
So, you know, a town hall kind of meeting is fine to let people come if they're willing to come and ask questions.
And I think that's also part of like, this seemed a little bit, well, and it didn't devolve, and I'm glad, but it kind of seemed like you had people who were pro and people who were con, and they were kind of debating, and that wasn't really what we were trying to do here today.
We got
If they want to host that where it's like, you know, ask Senator Rivera your questions, what do they call, they have all these fireside chat or something that we can kind of move people along. We can, I think that's a great board function to kind of facilitate that, publicize it, reach out to one of the many locations we hold our board meetings at and ask them if we can use their space. I'm sure Senator Rivera has his own, but kind of co-sponsoring that type of event. To me, today, and I might change my mind when I've had a full night's sleep, feels like that might be more beneficial to the overall cause of this bill.
Well, we could even say in a resolution, given we have heard from various members of the community, and we urge, we call upon the elected officials, who support this bill,
to have more transparent communication or answer more questions or host more information sessions or what have you.
And I think that might be the coda, right? Because as I was trying to keep flushing it out, it's like there's what your feelings are about the bill specifically and about the concept, and like. And again, we need to kind of really separate those things out for now, right? But I do think we could put something forward that simply says, this is the concept we support, including the language. And we strongly support, you know, the sponsors of this bill or any others like it to take these elements into consideration, in which I think articulates the fact that we do support the concept, but that there are things that need to make sure that are ironclad and addressed, right? Because I think that it is either the fear or the lack of awareness that is what's driving a lot of the debate and the resistance, right? If you knew for a fact this is what's going to happen, or this is how we're going to address these matters, and again, you know,
and it's a dense bill to read. So I think I think 90% of us, myself included, is getting it from a third party, from these white papers or this policy. And
so interestingly, the white paper that I gave you last night, sent to you this afternoon,
which I sat down and read 4 different times today and got interrupted every time.
Yeah, I didn't find it all that convincing in terms of supporting the bill.
And that's what makes it difficult, right? Like it's all of these think tanks, everybody kind of has an agenda. And like I said, I couldn't get through a white paper today. So some days I can sit, but I don't have someone smarter than me, or like maybe the authors, need to be able to sit there and talk about it, because while I know some of the responses to some of the points made, I don't know if that is codified somewhere. I don't know if that's what we're hoping is going to happen.
I spent some time going through the bill.
Yeah, like you've been knee deep in this for this entire term, and if you don't know, then I'm hopeless. I can admit that.
And I keep on looking for, where does it say who's going to set the rates?
Right.
Who's going to require a network, or is the State Department of Health going to say you must be part of a network?
And again, like I think one of the things that was difficult for me tonight is I was like, I think everything if somebody said tonight could be true. Like it, one of the things that struck me was the thing about, well, my insurance is really good, and most of us are, and I'm like, I had insurance, but it didn't cover my mental health care at a time where I was in a very dark place. And now I'm paying out of pocket $300 a week to see my psychiatrist to get my meds.
You can't get a psychiatrist.
I was very, very lucky. He was a friend of mine.
You can't get a psychiatrist to take any kind of insurance.
Well, that's why I was paying out of pocket and then I had to submit and then I got
Yeah.
this much back. I was going into debt to try to stay alive.
Right.
And I had decent insurance. It just didn't cover what I needed so like they can all be true.
Right, exactly. And I think the other thing too is even the element of, again, yes, you have insurance and some people, and so, you know, is the priority making sure that the uninsured are insured, or is the priority making sure that like what you pay for your good insurance isn't ridiculous, right? And again, these are all, again, there's it's.
And I feel like I'm oversimplifying this, but I'm like, couldn't we like phase this in? Like I feel like that has to be too simple.
Right. You know what? I mean, this is kind of like a land use committee issue where you've got to approve a demolition
Before
you can approve a building. And that's what you're looking at here. You're looking at taking apart
What everybody knows.
an institution,
For better
an
or for
industry
right.
that has grown up over 70 or 80 years. One of the ironies, I did a paper on this once. I have to see whether I can figure it out. Truman tried to come up with basically a Medicare for all back when he first became president. The unions opposed it because he was taking away one of their key bargaining points. And that's how the current health insurance system developed. There has been talk about Medicare for all, basically, a national health insurance program, going back to the early part of the 20th century. And now it's, I mean, you know, people are right. It's a for-profit. United Healthcare, which I used to work for at one point, not a healthcare provider. It's a stock. Yeah.
Sorry, and then I saw that thing about, I think it was AOC, who was like, okay, but you're CVS Caremark, so you're the pharmacy, but then you also have the physician. I'm like, this is a racket. I'm like, I mean, I feel like I'm not smart enough to say something like that. I don't know enough, but this seems like a closed circuit.
I mean, I've also, having worked for a healthcare company and a hospital, had from time to time, I had to write to the members of the health plan saying that effective January the 1st, they could no longer go to this hospital or that hospital because we couldn't strike an agreement. And then I've had to write to patients of the hospital saying that effective January 1st, you can't see your doctor at our hospital because your insurance company, I mean,
And if it's on the receiving end of that, my eye doctor, who I've been seeing for years, all of a sudden, same insurance, I went to make my appointment, we no longer take your insurance. So now I gotta find a new one and get, anyway.
All right. So,
I think we've beaten this horse pretty efficiently.
So that's it. So new business would again, the only thing we'll do is we'll work on getting this something in place for June. We'll have that representative from the Green Book. And I think we'll probably try to spend some of that next meeting kind of planning out what the next year will look like. And we will be meeting again on June 10th.
Yeah, I think that's
Same bad time, same bad
Same bad
channel.
Any motion to adjourn?
So moved.
Okay. Cool.
Thank you for sticking with us, and people who are still watching this recording.
know that there isn't anybody.
Yeah.
I do know some people will go back and watch it later.